Let's talk about third-line therapy. We've patients go into remission. You've given them R-CHOP to begin with, and then perhaps use the other therapy if as a second-line treatment when someone relapses. So what are our options in third-line therapy?
So good question. So most of us would start with either BR or R-CHOP, and then if you fail one, you switch to the other, depending on duration of the initial response. But when you fail both of them, and then what to do? Now we have two FDA-approved agents, both target PI3 kinase. The first one was idelalisib, and the second one copanlisib. And those would be perfectly suitable for this setup. In countries where these drugs are not available or there's reason not to give either one, most of us used to use R-squared, lenalidomide plus rituximab. So I think we have options here. The two PI3 kinase inhibitors are good options, and R-squared would be also another good option.
How do you figure out whether you need to add Rituxan? I know that actually in a lot of clinical trials, we just keep folding in the CD20 antibodies, not just rituximab, but any of the CD20 antibodies. I'm almost sometimes hesitant not to do that, but there's not a lot of evidence that you need it. How do you sort that out?
I agree. I tend to use it without rituximab when I use copanlisib or idelalisib. There's no data about the combination with rituxan would do better. It may add maybe more toxicities. We don't know. We need trials to see if the addition of rituximab is required, especially when, again, keep in mind that these drugs were approved for what's called double refractory. Ideally, when these drugs are approved, were approved for patients with rituxan refractory patients, so it doesn't make sense to add. But I'm sure there would be patients who may not be rituxan refractory, and the question, should I add rituxan? I don't tend to do that myself.
I think that in the context of lenalidomide, for example, even if somebody is rituximab refractory, that it may make sense to add rituximab because the mechanism of action of that regimen may be that those two drugs together really are more synergistic than alone. But I agree that if somebody's rituximab refractory and you're just adding it on, you're just adding on toxicity oftentimes.
So you talked a little bit about the mechanism of action of some of these drugs. So what's the rationale for the PI3 kinase inhibitors? That they work differently, right, than chemotherapy, than cytotoxic chemotherapy. What are your, can you
Well, I mean, that's a good point in and of itself, right? If you know that chemotherapy is not working, maybe just doing more of the same thing probably isn't the right strategy, and so looking for novel mechanisms of action is appropriate. PI3 kinase inhibitors, I think, make a lot of sense. I'm not sure that I would have known that before, but I think when you think of it retrospectively, or when you think more about it, we know that follicular lymphoma lives in a microenvironment with a significant dependence on signaling from that microenvironment, and if you can do anything to cut off that signaling, it's probably a good thing. If you take those lymphoma cells out and you put them in a dish, you can't keep them alive. If you could do that in a person, that would be a good idea. And so maybe PI3 kinase inhibitors work in part because they cut off signaling from the microenvironment. And so I think that's a rational strategy, and building on that makes sense by potentially combining it with other cell signaling inhibitors as well.
Greg, we know that there are now several different PI3 kinase inhibitors. They're different, right? There's 4 different isoforms of the PI3 kinase inhibitors. Idelalisib is thought of as largely a pure delta inhibitor, whereas copanlisib has inhibition of the alpha isoform as well. What does that mean for patients from a side effect standpoint and ease of use, and what are your thoughts on that?
Yeah, it's very interesting because there is some preclinical evidence that some of the resistance to PI3 kinase inhibitors could be mediated through the alpha isoform. So there is a strong rationale to inhibiting both alpha and delta isoform in the tumors, and in lymphoma and solid tumors as well. But alpha isoform is involved in a lot of metabolic processes in the body, which actually is related to very unusual and specific toxicity of alpha isoform inhibitors. So in case of copanlisib, you actually see increase in blood pressure, which is usually transient following infusion, but it's common in patients. And the other thing what you see is hyperglycemia, again, for the same mechanism of insulin resistance. Again, these are side effects which are common, but they're very manageable with appropriate therapy. And there are specific guidelines which are developed who should be observed and for the duration of observation after infusion. So it's manageable, but inhibition of alpha subunit does result in different toxicity profile. It is interesting if this inhibition of alpha subunit will result in a better tumor control, if indeed we will see some of the resistance, emergence of the resistance will be related to lack of inhibition of alpha subunit.
Could the inhibition of the alpha isoform also improve the tolerability in terms of perhaps the diarrhea that is sometimes seen with idelalisib? We know from the knockout mice or knock-in mice models that deletion of the delta isoform led to this colitis. It's not seen as much with copanlisib as it was with idelalisib. What's your take on that?
You're absolutely right. So it is not very common with copanlisib, which is actually a major advantage of this drug. And the mechanism could be inhibition of alpha subunit, but it also could be the route of administration. It is an IV formulation. Maybe the exposure in the GI tract is actually different to the drug, which may result in this different toxicity profile. It could be also related to drug metabolites and how it's being metabolized in the body. We know, for example, that liver toxicity is also very unusual with copanlisib, which is good to see because it opens more options for our patients.
Can I add one? And I doubt it's alpha is the one that is interfering with the colitis. I think it's delta is this the one that can. But I think I agree with you that it is the route of administration. You have a high peak and it clears quickly, so you don't have constant exposure to PI3 kinase inhibitors throughout the week. Whereas when you give it orally for some of these agents, you're constantly inhibiting delta, and that's probably what's causing it.
So is that enough to make you want to use an IV formulation over an oral formulation? I mean, there are clearly patients that would prefer to have oral, and then maybe there's some that would prefer to have an IV.
Well, it depends on the drug. I mean, it's for now, between these two commercially available, I think it happened that copanlisib has a better safety profile. It happened to be IV. I don't think the IV per se is the one. I'm sure we should probably at one point find an orally administered agent that also could be safe. So there are some early indication that some PI3 kinase are in clinical trials. They're giving also good early safety signal. Of course, long-term follow-up will be the important thing to find out if this is true signal or not.